Good day, everyone, and welcome to today's webinar, The Business of Compliance, a three-part series. Save the date for the 2nd and 3rd, October 7th and November 4th, noon Central. Our speakers today are Jerry Shafran, Maya Turner, who's a little behind, and Jay Ansting. At this time, all lines have been placed on mute to prevent any background noise. We will have a question and answer period at the end of the presentation. You can type your questions using the question prompt. They'll be answered in the order they were received. When typing your questions, please identify the name of your organization at the beginning of your entry. This webinar is being recorded and will be available in the CIHQ YouTube library within a few days. It's now my pleasure to turn the conference over to our first speaker, Jerry Shafran. Jerry, you have the floor.
Thank you, Michelle. I want to start by, first of all, thanking the CIHQ for the opportunity to bring together these two experts, Maya Turner and Jay Ansting, to talk about the business of compliance for quality professionals. In addition to thanking the CIHQ, I want to thank Jay and Maya. And Michelle mentioned it in her introduction, we are having a little bit of technical difficulty with Maya, and our hope is that she will be joining us shortly. So with that, let's go ahead and get started. I want to start by, first of all, talking about the 3-series webinar that we put together with CIHQ's help. The webinars are designed to help quality professionals and compliance professionals get more effective as it relates to both business and the business of healthcare. In our role and what we've done within being a vendor, one of the things we learned when we talk to a lot of folks in compliance and quality and also in some of the risk and audit areas is there's a real thirst for knowledge about how the business of healthcare really goes on, how it works. So our first webinar today is going to talk about the business of compliance and quality with Jay and Maya. Our second webinar, and I really hope you have a chance to join us for it, it's mastering compliance communication and financial fluency. It's gonna really focus a little more on the financial fluency stuff. We did this webinar for the HCCA last year, and we had hundreds of people attend. And basically, the financial fluency webinar is going to talk about what are the important aspects of a P&L, what are the important aspects of a balance sheet and a statement of cash flows. And as a compliance or quality professional, what pieces of those documents should you be focusing on and looking at? A great way to accelerate your career is to have more tools in your tool bag as you're talking about the way healthcare and business is run. The third and final webinar will be in November, and we'll have the actual dates at the end, which is leading compliance and quality teams. A lot of folks in the compliance and quality arenas have expressed to us that when they get put into leadership positions, there's not enough training in terms of how to do and be a leader. So we put these 3 webinars together in the hopes of helping prepare people to be in more leadership positions and bring the tools necessary to be an effective leader. So it looks like Maya is still not with us. So what we're going to do is we'll start with our agenda, and we're actually going to flip things around a little bit in terms of slides until Maya shows up. Our agenda starts with aligning for patient safety, and that's really going to focus on some educational stuff. Next, we'll talk about preventing deficiencies and avoiding CMS penalties. Next, we're going to talk about the 7 elements of an effective compliance program. For the compliance people on this webinar, this is probably something you're very familiar with. A lot of people that we talk to in quality have some basic knowledge about the 7 elements, but we thought covering it would really make sense. We're then going to start to move to more of the business side of our webinar. So it's the hospital bottom line for quality professionals and demonstrating value for the compliance and quality teams. For those people who are on the webinar today that are compliance focused as opposed to quality, or if you're doing both, we know that compliance professionals struggle demonstrating value throughout their enterprise. So we're going to talk about ways and strategies that you can do that within your organization. And then last but not least, compliance-driven quality improvement. So this is today's agenda. So we're going to actually skip this slide, and we're going to go to this slide. And Jay, what has been your experience with how compliance and quality can interact? And there's actually an analogy that we talked about in the lead up to our presentation. This might be the actual analogy, I'm not sure, but Jay, tell us a little bit about your experience. Oh, by the way, Jay, a little bit about your background. I apologize, I should have done that at the kickoff.
Yeah, thanks, Jerry. Yeah, just quickly, a little bit of background on me. So I have been in healthcare for 25 years, lawyer by background, have been in the compliance area for over 20 years. Majority of that time has been spent in and around hospitals and health systems. I did spend a few years working on the physician practice side, and I've also worked on the payer side as well. All of which was doing compliance. And yeah, we were preparing for this, and I kind of throw out this analogy, sort of maybe it's coming up with football season, so football was sort of top of mind, but is compliance kind of being the quarterback. And it really depends upon the particular situation scenario you're running into. But what I was talking about with Jerry and Maya as we were preparing for this was, if we have, for example, an investigation comes up, and it's something we're trying to figure out what's going on, typically the compliance officer, if it's compliance related investigation, then the compliance officer would oversee that, sort of as a quarterback, but they're going to rely heavily on others or their teammates, if you have sort of an investigative team, to help with gathering information, analyzing information, things like that. So a lot of times we might have an HR person there that's there to help guide us when it comes to potential corrective action or our HR policies. The department supervisors, if it's an employee that's alleged to have done something wrong, we lean heavily on the supervisor to help us with gathering information specific to that particular department and processes and how they should work and things like that. And then with regards to risk and quality, that can also come into play as well if you have a particular situation that is not only a compliance issue, but also a patient safety or risk issue. A quick example might be a nurse on the floor that's suspected of diverting a controlled substance or something like that is a compliance issue, but also could be potential patient safety or patient harm issue as well. So that was sort of the analogy, was in that particular instance, compliance being sort of the quarterback, and then having the other teammates that are there to help facilitate and assist the quarterback as they're moving the ball down the field, so to speak.
So let's dive in a little deeper into how those two, those two functions, the compliance quarterback and the quality player. Let's dive in a little bit deeper in terms of how they actually work together. And we've got some specifics. And Jay, what I'd like you to do with these, if you don't mind, is start with each one and give us some detail. Give us some detail on how document standards and incident reporting and things of that nature, how quality and compliance can work together in terms of increasing patient safety.
Yeah, absolutely. And actually, one thing I was going to add on that previous slide was just to comment that the roles can be reversed too. So I've been on the other side of the equation where you're getting ready for a JCO survey or another type of survey, and it's the quality department that is helping assist with the survey prep readiness, and they're leaning on others, their teammates, to help make sure we've got all the processes and procedures in place. Everybody's aware of what the requirements are. Everybody's aware of how the survey is going to go when that time comes. And compliance can definitely be involved in that sometimes too, depending on the nature of the survey.
So Jay, a question. Your background, and I might be putting you on the spot here. This isn't something that we did in prep, but
Sure.
It's just you and me, so we're gonna wing it.
Yeah.
You've historically, I think, worked mostly in large organizations. Is that true?
Correct. Yes.
So in your organization, that compliance quarterback and quality player, again, I'm putting you on the spot. If the answer is you're not sure, say it. It's not uncommon that I come across in smaller facilities someone who's wearing both hats.
Yeah, absolutely. Yeah, that does happen. Certainly in a smaller type of organization where you might have multiple people wearing both hats, compliance officer hat as well as quality as well.
Does that ever Does that ever create any kind of conflict or not really?
You know, I've personally not seen it as a conflict. I think the most important thing is just to make sure that as they're working on a particular issue, they're aware of, you know, always aware of what particular hat you're wearing, you know, which most typically they have been in my experience. You know, if you're working on a particular issue that's trying to get resolved, obviously you're going to be looking at it. If it's the same person, you're going to be looking at it from a quality perspective. So for example, what is the possible risk to patient care, patient safety, things like that? Do we have reporting obligations that we need to meet? And do we need to put auditing or monitoring in place, something like that from a patient safety particular standpoint, as well as do we need to revise our processes in order to improve patient safety and patient quality? And then on the compliance side, they might be looking at it from a compliance standpoint of meeting Medicare conditions of participation regulations or possibly billing regulations if there's a particular service that's at issue, and making sure that you have the right medical record documentation to support billing out for that procedure. And if you don't, then making sure that you take the appropriate steps to refund that money in a timely manner according to the regulations.
Okay, great, thank you. And again, if I ask something, Jay, that puts you on the spot, feel free to tell me that's not what I want.
Sure,
Okay.
no problem.
Let's go to our next slide. And on our next slide, we're going to talk about some specific examples where compliance and quality can work together and create this concept of shared goals for patient safety.
Yeah, absolutely. And so I think, you know, the really kind of the purpose of this slide was to kind of work through just some examples of where, you know, somewhere what I was alluding to on the last slide, where we do have some overlap between the two departments, but we may be looking at things from a different perspective. But at the end of the day, we do have a shared purpose or shared goal often. And so I think it does naturally lend itself for really good alignment. And in my case, it has in the past. I've always had good relationships with the quality folks that I've worked with. That first one on documentation standards. So, you know, just to give an example, let's say that what is at issue is billing out for a cardiac related procedure, a valve replacement procedure, or any type of major substantial cardiac procedure. And oftentimes with those, there's going to be really rigid criteria that are set in place by CMS, for example, if you're going to be billing out for those services for Medicare patients. There has to be shared decision-making oftentimes between the patient, referring physicians, and the surgical physician. That has to be met, has to be documented, has to be in the medical record. This often has to take place over a period of time, has to be before the procedure actually is performed. And then, or, you know, another example might be with knees, total hip, total knees. Actually, that's probably a really good example. Because with total hip and total knee replacements, there's a lot of documentation criteria that you have to meet from a billing perspective that compliance is going to be focused on. And in that particular case of total hips and total knees, you have to document that there's been some period of time in history where you have exhausted what they typically refer to as conservative non-surgical treatment. So if you think about a knee replacement, you know, the use of pain medication, use of physical therapy, use of other things that are not surgical interventions, and that those have failed, and that this particular patient is a candidate for this particular total hip or total knee replacement. And so a lot of that times that has to be documented, or not a lot of times, it has to be documented in the medical record. And so because it's a high dollar procedure, that typically equates to a high risk procedure from a compliance perspective, and making sure that we're not having to unnecessarily refund that money. And if we worked hard to earn that money, we should be able to keep it, but you got to make sure that's documented. We got to make sure that we meet the regulatory requirements. So we might do an audit within the compliance department, and we would be looking specifically to make sure that those criteria have been met such that we can bill out. And if not, then we need to refund and return that money. On the quality side, similarly, might be looking at the same thing and making sure our processes are such that we aren't experiencing unnecessary readmission rates from those patients that have had surgery, they've been in the hospital, they've been discharged, now we have to readmit them because there was a complication. And so a lot of times what you'll see is within the department, they might put really good front-end processes in place to make sure that that documentation's there. They've got a nurse navigator in place to do the education and training with the patient so that they know what to expect before the day of the surgery and things like that, to try and reduce those complications on the back end. So that's an example where you might have the same subject matter area, but looking at it from two different lenses, from two different, particular standpoint. But at the end of the day, what we're trying to do is that shared goal, making sure we've got accurate, complete, and timely patient records that would support billing and also support patient safety.
Jay, I have a question, and this is my question. This may not be as applicable to the audience. This is from my edification. So compliance focus, quality focus. In your mind, is compliance focus more regulatory in terms of how they look at things, and quality is more accreditation focus? Or, an accrediting body like a CIHQ comes out with a set of metrics and quality standards, and a compliance person has to deal with CMS, OIG, or do they intermingle? There's no real clear demarcation.
Yeah, it is intermingled. I think in my experience, every organization varies a little bit with how they kind of navigate those lines to try and make it as clear as possible. I know in some organizations I've worked in, for example, compliance would deal with billing related regulations, hospital physician transactions, contracts, and things like that, HIPAA, but they might not get involved in scope of practice type issues, which I think almost always are going to be something governed at the state level. Whether or not a physician assistant can order a particular type of procedure or exam or something like that, or does that have to come from a physician?
So it's not clear. It's not that clear. It depends on the specific set of regs or accreditation and who it applies to. I got it. Okay.
Yeah.
Honestly, I'm sorry.
Oh, I was going to say, honestly, the best way I've seen to approach this, just to try and make it clear, is sort of the nature of what's being regulated. And if it's administrative, billing, financial, things like that, it might fall more on the compliance side. If it's clinical, not always, but in my case, certainly, I don't have a clinical background. And so it would not do the organization good to have me overseeing things on a quality clinical side. So you would want somebody that has that background, has that expertise. And oftentimes you'll find that it's clinically related folks that are going to have that quality background and be able to have that expertise to oversee that particular area. So they might be in a better position to provide an opinion or investigate a matter or address an issue that's related specifically to clinical quality of care, where compliance might not be.
Cool. You want to quickly touch on incident, medication, and patient rights?
Yeah, so, and really, I think at least with probably the incident reporting and medication management, I think we could probably tackle this in one example or hypothetical, and that would be, I alluded to this a little bit earlier, but let's imagine we had a nurse that was on a floor that was suspected of diverting fentanyl or something like that, and there's an investigation, and it's there's evidence that's substantial enough to determine that the allegation is accurate, and there is a potential patient safety risk. I've seen some instances where they were syringes that the individual was injecting into themselves. They had something like hepatitis C or something that could be transborn or it could be bloodborne, and passed on to patients, and they were refilling those dirty syringes with saline. Those did go into patients. I've seen things like this happen, unfortunately, in the past. Not with organizations I've worked in, but ones I've worked in the markets I've worked in. And so there's a whole host of issues that can come up where you see quality and the compliance side, as well as, at the advice of legal, working on some of these issues together. But drug diversion is probably, an example where you have investigation. The incident reporting piece is going to be, in that particular example, it's going to be the nursing board. Typically, if you got a confirmed case of it, it's going to be a mandatory report to your state medical or state nursing board, excuse me. And so that is going to be something that not only quality, but compliance is going to make sure does happen. You've got documentation that those steps were taken if it is something you have a mandatory obligation to report. And then on the patient safety risk side, through the course of investigation, doing a root cause analysis or something like that, you might determine, okay, we have a loophole, or we have potential here in our processes where somebody is able to divert drugs, and we need to close up that process. And so we might, again, do a root cause analysis, take a look at what our processes are, and figure out how we can tighten those up. So that's another area where you might see compliance and quality as well as operations working together to try and address an issue. The medication management is really, the overall comment is there's all kinds of regulations around how you're ordering, dispensing, storing, administering controlled substances, and making sure you're complying with those regulations, not only from a Joint Commission standpoint, but also from a regulatory standpoint. And so that's just another example where you see both departments with a shared goal, but they may be looking at from two different lenses.
All right, let's move on to the 7 elements of an effective compliance program. Now, before we do, a couple of concepts. As our audience will notice, there are 6 elements here. This is actually, we noticed this at the 11th hour. I did want to point it out because for those of you who are our audience, we didn't want you going, hey, these guys don't know what they're doing. This is what Maya was trying to fix. And one of the reasons she's had trouble getting in is she was trying to fix the 7th element, which is down at the bottom. But Jay, why don't you tackle these 7 elements, and to the best of your, I know you know them inside and out, but the stuff to the right, if there's anything you can bring to it, and you'll see on the left side of that slide, dear audience, it's the 8th element. Jay and I are going to have a little argument about what we think the 8th element should be, and obviously he will win because he is in the industry and I am not. But go ahead, Jay, take it away.
Yeah, so, really on this slide, I'll do my best job to do my Maya impression. So a couple things at the background, which is ever since the late 1990s, we've had these 7 elements of an effective compliance program that were put out there by the OIG, and that has been really the infrastructure that has set up compliance departments over the years. And things like having policies and procedures in place, having a compliance committee, a dedicated compliance officer, doing communication or education and training, having what's called an open line of communication or an ability for people to report issues in, doing investigations, and then if you have some type of issue that's confirmed, doing some type of corrective action that not only corrects whatever issue came up, but also is taking the step to prevent a future occurrence. And that's similar to the enforcement disciplines, very closely aligned with that, because you might have corrective action on the back end, whether it's refunding Medicare overpayment or it's terminating an employee for violating a policy or regulation or something like that.
Jay, one second.
Yeah.
I think we have audio of Maya. Maya?
I am here. My camera is spinning. My computer has been doing something that I cannot explain. Maybe it's a ghost in the machine, but maybe it needs to be reviewed under the compliance program. But in any case, I am here, and I do apologize for the delay for all of you who have been on, but I finally have made it on, but I'm still having some problems with my screen sharing. So not my screen, but my camera. So I apologize. I'm not sure what's happening here. But
Maya, can you see the slide we're on?
I'm sorry, what was that last part?
Can you see the slide that we are on?
I still didn't hear that last part. You kind of went out. So can you please repeat that last part?
Can you see the slides?
I can see the screen, yes.
Okay. So you can see the 7 elements slide that we have up?
I can. Yes, I can.
And
Jay, go ahead.
Yeah, I was just going to say, Maya, and so I was just kind of working through the 7 elements, just a little bit of history on the background, and then kind of what each of them are as a foundation for compliance programs. And I know we had talked about how, I think in both of our opinions, a lot of the folks on the quality side are already doing a lot of this stuff, but they may not realize it. But
Yeah.
I'll sort of turn it over to you and kind of can help work you through on this one too.
Yeah, I think, when we're dealing with the compliance, and I think it's just a time where CQOs and CNOs and compliance personnel all need to be kind of on the same page. Now, we all know that from a compliance perspective, you know, everyone has their duties, but because a lot of the components that have been in place for quite some time now, when it comes to value-based care and the alternate payment models and value-based purchasing, now CMS is really going to penalize providers with a lot of the initiatives. So, you know, when we think about quality, we think about MIPS, and everybody knows about MIPS and value-based purchasing, right? But now we're getting ready to unpack the herding, if you will, to a value-based care, or value-based care is really managed care, right? And I won't go into a whole lot, but now it's a quality managed based model where CMS is really looking to monetize quality perspectives, and it's not going to be affected just on the MIPS and the alternate payment models, but on the back end. So at the end of the day, you know, when you deal with the clinical process and the value-based purchasing and the infection prevention, right, then if there's any adverse events that relate to that quality, now it's going to result in a revenue loss. And because of that, we really need to lock arms and interchange the circles instead of it being separate, and making it into such that it creates a uniformed alignment so that the revenue is increased rather than the opposite, based upon these measures that are related to quality, and working with the compliance team and getting all of these things into place.
And on the screen, Maya, so we have the 7 elements, and then there's boxes to the right that I believe those are examples, kind of like what I was saying earlier, where a lot of the work that quality is already doing kind of fits into one of these. I don't know, we've got 6 on there, but fits into one of these.
Absolutely.
Right?
Absolutely. I mean, and you think about the internal, I mean, especially the internal monitoring and the clinical process of care, right? If we have the internal monitoring, right, and the clinical process of care, all of that kind of coincides, right? The patient experience, the communication, right? If there's an adverse effect, if there is a negative experience, right? Those types of things are really going to what's the word? Highlight the need for training, right? Because again, at the end of the day, when there is something that is ineffective, we have to retrain, right? And how does retraining affect? It's part of the compliance program of training and education. So that should be like the borderline, not the borderline, but the baseline for everything that is related to compliance, quality, all of it, right? And so when we think about this and we think about the clinical process and even the lack of training, right, could be a result of infection, but then you have to do the infection prevention, right? So all of these things kind of come into play, because if it's not training, if there's not a foundation, there is adverse effects, in turn leading to revenue loss. Yeah.
Okay, so Jay, let's have our discussion about the 8th element.
Okay.
From your perspective, you believe if I remember correctly, actually I don't want to put words in your mouth. Do you remember when we had our run up what you said you thought the 8th element should be?
Yeah, evaluating the effectiveness of a compliance program. That was.
Yeah, whether or not a compliance program was effectively evaluated. And I assume when you say evaluated, you think it should be evaluated on a regular basis.
Yes, and that's based on increasing guidance that we've gotten from the OIG over the years. When it first came out back in 2005, it was sort of, well, it's a good idea, you should do this, you know, every once in a while. And then over the course of the last 5 to 7 years, we've gotten updated versions of this that have really strongly been hitting on that. And what's really changed from a tone perspective is the focus has not just been on the compliance officer, it's been on operations. And asking questions like, is operations ignoring the advice of the compliance officer and things like that. So it's really kind of interesting right now, this particular period of time, where they're trying to focus on that collaborative partnership relationship between operations and compliance.
And the guidance, the OIG guidance from, I think it was late 24, it might have been 20, yeah, it was 2024, absolutely reinforces what you said. My argument with that is that at the foundation of a compliance program is regulatory change management and the ability to keep track of, monitor, decipher, and ensure that your organization and all the different parts are keeping up with regs. And we actually, as we got through our conversation, I asked you the question, if a regulator came in and said, and came to you and said, what did I write here? Which is more important when a regulator comes in? I evaluated my compliance program, or I'm not keeping track of new regulations. Which would you say is more important from a regulator?
Yeah, probably the regulations piece of it, because obviously that is going to be important. And I have seen some organizations struggle with this, where there's a lot to it and it's always changing and you got to stay on top of it. And if you don't have the right processes and infrastructure in place, things slip through the cracks. And then the frontline folks don't know what the rules are, or that the rules had changed and nobody told them. And then you come and do an audit or something like that and then you start to find this out. And then now you've got a bunch of repayments and things like that. And so it is something, early and often is the best advice in that area for monitoring regulatory changes.
So in the interest of time, basically the bottom line, all three of these are, quality and compliance are absolutely critical when it comes to, the revenue and the ability to get it and retain it and have what is referred to in the industry as integrity associated with that revenue, so that you can rely on it and it's not going to get clawed back and you're not going to have any issues with it. From a revenue perspective, Medicare uses quality measures to reward providers for compliance and quality. Maya, can you talk a little bit about those incentives? Actually, am I on the right slide? Yes, I am.
So,
hey, Maya.
hello. Yeah, I'm trying to get my screen thingy to work, but I mean, there's nothing that's working right properly these times. So I don't know what's happening. I'm ready to stab my computer and throw it out the window and set it on fire. So those of you who can understand and get with me, let's all burn, instead of Fahrenheit 451, let's burn our computers.
Okay, we're going to move on to the carrot and stick reimbursement model. Maya, this is something that I don't think you need your computer for this. It really was something that you talked a lot about.
Right.
Was the stick being quality and the carrot being the ratings and all that. Why don't you take that away?
Sure. And again, I apologize, everyone, for my computer misbehaving. But again, when we're thinking about the carrot and stick, we also think about the models, right? And everybody knows that there are models that are based upon reimbursement. And we think about MIPS, the metric improvement performance systems that are used to rate good quality versus bad quality, right? And so when we think about these things and we think about MIPS as a whole, we think about how organizations are rewarded for great scores, for high scores, and there's a revenue loss when there's low scores. So what I want to introduce in this particular piece is that when you're dealing with the 2026 rule, proposed rule, and then there's a final rule that's out for the 2026 proposed rule for the Medicare physician fee schedule. For those of you who are part of larger organizations, they are now proposing that if you are part of a qualified participant in these MSSP ACO type programs that is related to value-based care, they're going to reduce your payment if you're not a participant versus if you are a participant. And what has also been introduced for the final rule is a team episode based model, where there is going to be some team facility-based bundle payments that are factored into reimbursement for adverse quality. So at the end of the day, what it all really means is that if you don't meet certain quality performance, you are going to lose revenue. That's it. That's all. End of story. And we're not in a day and age where we can just optionally say we don't want to participate in that. If you choose not to participate, you're going to lose money, and it's going to be I mean, and if you're not really having those robust and meaningful conversations with those who are involved with quality and compliance, because at the end of the day, it's really going to be about that. And it should, like I said, it's a day and age where you need to start locking arms and having those meaningful conversations regarding those reimbursement changes. One, because if you don't, you're going to lose money from the back end because you're not getting the stars. And then two, if you're not participating, you're going to lose money on the front end because you're not going to get the money from the physician side, the work RVUs, or from the facility side, from the team-based model. So there's a whole lot of things that are listed here that are really driving, and I don't want to say force, because force is a strong word, but I'm going to say force because it is a strong word. And by the time 2030 hits, they want all participants or beneficiaries who are in the Medicare program to be in some sort of value-based care program. So
Maya, should I be on the advanced alternative payment model slide?
well, no, because all of this is kind of related. The advanced payment model slide and all of this is kind of driving the reinforcement to really say that at the end of the day, if you're not involved, you're going to get hit. And they're really, these last 4 years of the Medicare program are really going to drive the pulse of how all of this is going to come into play. Really, truly.
So I'm on the value-based care and payment models. I know you can't see me. I was trying to keep up as you were going. Should I now move to the APPM, the advanced alternative payment model?
Yeah, sure. You can move on to that.
Okay. Maya, take it away.
Okay, so as we talk about these programs and how we have these alternate payment models, you have MIPS, and again, when we're thinking about these alternate payment models, it's really kind of driven by these metrics, right? And we all know what MIPS is, and MIPS has been around forever, going back probably before 2019, because there was always some sort of the PQRS scoring, and then they translated to MIPS and all of that stuff. So when we think about the alternate payment model participation, right? They have introduced in 2026 for the physician fee schedule that there's going to be about a 30 cents per work RVU reduction for non-qualified participants, right? But then we also have how this is going to kind of hurt, like I was stating before, all of the Medicare fee schedule patients to the value-based model. So in my experience in a very large organization, they have implemented a lot of these programs to kind of be involved with and take advantage of participating in these types of models that are associated with value-based care. So you might be thinking, okay, well, Maya, I don't really know what you mean by value-based care, right? Well, think about the advanced care planning. Think about transitional care management. Think about the primary care management model that they introduced in 2025. All of these things are quality measures that are driven by chronic conditions being managed and or maintained to create a higher level of quality outcomes for providers and or facilities to get a higher reimbursement amount based upon these scores. So when you think about this from a larger perspective, gosh, you're doing this already. So if you're doing this already, then officially enroll in these types of programs so that you can receive the benefit on the front end. Because now on the back end, you're getting the MIPS, you're getting all of that. But honestly, the more they drive these alternative payment models, the further away MIPS is going to go away. And I don't know if anybody who's on here who already participates in MIPS, but now they've, streamlined it. So now the qualifications are like maybe 4 or 5 bullets, and I'm really exaggerating, to fit into this model for you to get extra money, which is pushing you to go to the front end to get this reimbursement from the front end perspective and not the back end. So again, as we have in our very last bullet, the back end payments are really going to dwindle down, if you will, because the metrics are really going to be pushing for the front end rather than the back end, if that makes sense.
What is the witch's brew?
I love this. I love this. And you see the little witch. I kind of like Cynthia Evo's Wicked perspective, and she has a much better voice anyway. I don't know if she can sing, but in any case, when we think about the reimbursement of magic, you have like the CMS stars, right? And the CMS stars are all of the things that you're doing that you're getting for all these quality measures. And then you have the value-based care metrics, right? Which are all of these things that are related to chronic management, right? And then the readmission rates, and then, the things that, we talked about in the comparative slide for the 7 elements of compliance and the quality metrics program. And then you have the merit-based incentive that I just talked about, that the list in order to get these reimbursements are smaller and smaller, which is pushing you to go to the advanced care model. So we have all of this brews that she's stirring up, and you have all of the smoke that's coming out, right? Well, I won't say smoke screen, but I will say that a lot of these things that are associated with this brew is really going to make the difference on how, at the end of the day, providers and facilities survive if they don't meet these metrics. So, the end of the year used to have the HEDIS measures. They have, which is the healthcare effectiveness data information set. And then you have the value-based care models. And then you have MIPS. Well, the first two are really going to be driving how a lot of the reimbursement is going to take place. The MIPS is going to go further and further away, like further down the hallway, if you will. You know how in Poltergeist, when she was running down the hallway, and every time she would run towards the hallway, the door would get further and further back? Well, that's what that's what the MIPS is. It's going to go further and further back the closer you get to it. So now we need to start thinking about the upfront quality metrics. You need to have the CNOs and the CQOs need to have that meaningful conversation so that the circles are interchanging to create the secret of the reimbursement magic. And this secret is collaboration. This secret is fluidity with this collaboration and consistency with meeting those metrics.
Okay, Jay, I'm going to ask you to talk very briefly about the VBC rewards on this particular slide. I think this is the right slide with it. And then we did already touch on final rules, so I'm probably going to go past the next one.
Mm-hmm.
Jay, is this the right slide for VBC reward?
Yeah, for provider-based departments. Yep. So this was, we put this in to kind of highlight another example of alignment between quality and compliance. And so for those that may not be familiar, there's a set of regulations governing what are referred to as provider-based departments. It's a Medicare designation. Essentially what that is it's any department that is billing as an outpatient department of a hospital and billing out under the hospital's TIN and other ID numbers. And they're getting that reimbursement, which is typically a higher reimbursement as a provider-based department, as opposed to a freestanding department. So just a quick example there would be, let's say you have an imaging center that's doing x-rays and MRIs and CT exams and things like that. That potentially could be structured to be a freestanding department somewhere within the town, or it could be set up as a PBD, which could be either within the four walls of the hospital, or it might be on the hospital's campus, but outside the four walls and within a certain number of yards of the main building.
Right.
So we can probably already tell the way I'm talking, there's very, very, very technical rules around PBDs. It's an area that's historically had a huge microscope under it within the last 10 years when the regulations changed. I think because there was some concern that some providers out there might be gaming the system, where they're billing out as a PBD, but they're not actually meeting the PBD requirements. And so there were some regulatory changes with that. And this is an area that some hospitals and health systems across the country have struggled with. The last bullet point has really the structure of these PBD rules are that you have to be, if it's an outpatient department of the hospital and you're billing it as such, you have to be clinically, operationally, administratively, and financially integrated with the hospital. And so what that means is, connecting that to quality is if there is a quality related issue that's related to some provider that's providing services in one of these PBDs, that has to have the structure to be able to report that issue up through the hospital and be under the peer review and quality departments within the hospital to be able to look into and address those particular issues. You can't have it as a separate entity. So sometimes what can happen is organizations get in trouble where you have a hospital or health system that's operating a PBD, but then they contract out with a physician group to provide those services. And so one way or another, that physician group still has to meet the hospital's quality measures. They still have to meet their peer review criteria. They still have to meet their medical staff privileging and credentialing requirements and all that kind of stuff. So, and there has to be evidence of that you're integrated. And so a lot of times, some of that integration might look like making sure that you've got those issues getting reported up through the hospital's quality council or peer review committee or whatever mechanism might be in place to review those particular types of issues.
So we're going to talk about a real world example. This is a $5 million loss. Lessons from compliance and quality of fail. We are starting to get up against the clock. So if Maya, if you want to start with this $5 million missed revenue or missed revenue concept, please.
Yeah. Let me elaborate on that. So a lot of times when you have, and let's just backtrack just a little bit. Quality and compliance and is not just limited to the care in the hospital. It really should be about everything that is associated with the care in the hospital. So when we think about high tech and the usage of the system and its effectiveness and being able to capture certain things from a clinical perspective, this $5 million revenue loss came from how a lot of the services from a provider-based perspective, which is what Jay was just speaking on, where the EHR wasn't capturing effectively the wraparound for the facility charge to bill. So for those of you who are not familiar, there is a facility and then there is a professional charge that is both created in tandem for provider-based department services. Well, what wound up happening was that a lot of the claims that had gone out from its inception, and I will just say from 2025, missed the facility charge. So when we think about EHR compliance monitoring and the revenue impact of making sure that it works effectively, if that measure had been taken from a quality perspective to make sure that the EHR is producing quality revenue output, they would not have missed what is equivalent to $5 million in losses because of all of the facility-based dollars that didn't go out the door. So you have to think about not only from a quality perspective, but think about the revenue perspective and the EHR and its ability to produce revenue for your facility. But if it's not there, you're going to lose money because EHR is also part of the program to make sure that you are making sure that it's used and it's effective and its effectiveness. Having quality measures and revenue is just as important with having quality measures with patients. So you got to think about how all of this kind of transcribes and kind of is an interlocking circle that could create some impact in your revenue if it's not paid attention to.
Jay, you had talked about the concept of ticking off boxes when we discussed this. I think what you said was, actually I wrote it down, actually it was written down for me. Quality doesn't necessarily equate to just ticking off boxes, but ticking off boxes to get more money is essential.
Yeah.
You want to elaborate on that a little or not?
Yeah, well, we're getting to the right. Yes, yeah. I mean, it's all about making sure that I guess it kind of means a few things to me. One is just making sure that when you're revising or setting up processes or making sure that you're doing things to meet the regulatory requirements, that the audience understands what that is, and whatever those changes are such that it's going to be user friendly and it's going to work for whoever that end user is that's going to have to live with the regulations. And so a lot of times it may not necessarily be a check the box. Sometimes checklists are good, but in other areas sometimes it's more important to do something that's a little bit more impactful from the audience perspective.
So we're coming up against the hour. So I'd like Jay and Maya's takeaways. We'll go ahead and start with Jay.
Yeah, I think, the biggest thing, I know we talked earlier about the 7 elements and that being the structure for compliance programs. We also talked about the compliance program guidance, as a reference to this is something that's come out periodically that measures the effectiveness of compliance programs. The biggest thing is if you haven't seen this, we obviously spent a lot of time talking about how compliance and quality are doing a lot of similar work or in similar areas, and they're potentially partnering together and have shared goals. But I think one of the things, if you haven't seen it already, you're going to probably start to see is a little bit more involvement and engagement with your compliance department. Because the government has been asking for quality to be more baked into compliance program requirements. So if you're not already sitting on your organization's compliance committee, you may get an invitation to that. If the organization does a risk assessment, every year compliance departments do a risk assessment to identify what areas they want to do auditing or maybe investigation or education and training. They're now being asked to make sure that they're taking into account quality related metrics. And so you might see more requests for data sharing on things that might traditionally be patient safety, patient harm type issues, but there's a compliance component to it. And you just may start to see more of that involvement, and just know that that's not necessarily coming directly from your compliance people, but it's coming from the OIG that has put out these new requirements.
Yeah.
Maya.
I would say be very mindful of the integrity of the dollar, right? You want to make sure that if you have the dollar that you're able to keep it. And now the dollar is not related on how just you go out to bill for services and if it meets those metrics, but it's also clinically driven by the quality metrics that's associated with that dollar. So in other words, quality and compliance and revenue coding compliance all equal the integrity of the dollar. And your compliance program, along with your revenue cycle integrity team, should have a plan in place in order to keep the integrity of the dollar by means of quality, by means of value-based care, because it's the wave of the future. And by 2030, I promise you, you're going to see a lot of the Medicare beneficiaries, which are the goal, to be a part of ACOs and Medicare shared savings programs to keep the integrity of a dollar by means of quality. So there should be a lot more conversations that are involved with quality assurance, revenue integrity, and payment that's related to that dollar.
Okay, so before we go, and before I turn it back over to Michelle, I don't know if anyone has noticed, as the moderator, I'm wearing a t-shirt. The reason I'm wearing a t-shirt, these are t-shirts that we give away at conferences. If you're coming to the CIHQ conference in San Antonio at the end of this year, please consider coming by our booth and getting an I'm Just a Bill t-shirt from Schoolhouse Rock. Hopefully we'll see you in San Antonio. I'm doing a presentation there as well. And this is everybody's contact information if you want to reach anyone. The second webinar is October 7th, same time, 12 o'clock Central, 1 o'clock Eastern. The third webinar is November 4th, also the same time. Michelle?
Thank you, everyone. And as a reminder, you can type your question using the question pane. Please identify the name of your organization at the beginning, as this gives our speakers insight into any special considerations that need to be addressed. And please be sure your question is worded clearly. Okay, our first question comes from Caro in Kentucky. What is a good first step for me as a quality person to start building a better relationship with compliance?
Maya, you want to take that? Or Jay, either one? Good first step.
Well, sure. Well, what first thing is, I think that there has to be a meeting of the minds, right? I think there needs to be a unified language. And I think the first thing in understanding the unified language is to understand each other's needs, right? To be effective in communication means that you have to have two parties who can effectively communicate each other's needs and being able to walk away understanding. So at this point, you need to understand the needs of quality, and quality needs to understand the needs of compliance. Once that is met, or there's a conversation, then you can understand each other's needs and how it translates to each other's department. And in my experience in working with very large organizations, that's exactly what happened and how it translates to revenue. And once that communication is in place and you're able to have a meaningful commonality, then you're able to move forward and create policies that would be meaningful for reimbursement to be met and to be enforced by each other's staff.
Jay, anything to add? If not, we'll go to the next question.
Yeah, the only thing I would add is just kind of on the compliance side, and that is if you don't necessarily have a very strong relationship with your compliance officer, that's something I would work on kind of the compliance end, which is, hey, if you don't know your quality folks, then you really need to make sure to reach out and work with them and better understand what it is that they do and how that you can work together, on particular issues and things like that.
I'm not in either of those industries, but I'll add one quick thing. I've been doing what I do for 45 years. If you're going to someone new, look for ways you can benefit them.
Mm-hmm.
Look for ways you can offer a benefit.
Yeah.
Michelle, any additional questions?
Yes, sir. There's another from Kentucky. Who owns responsibility for monitoring setup in an example like the PBD? Pardon me.
Oh, I can take that one. Yeah, I think it's going to vary on subject matter because, at least in my experience, when it comes to monitoring, quality is already going to have a lot of metrics and initiatives that they're already trying to support where they're doing monitoring, and compliance will as well because of part of their development of their auditing and monitoring program each year, which usually comes after they do risk assessment. And kind of to my comment earlier about you might see more integration between the two, that might be a scenario where, with compliance committee meetings and things like that, they might start including the reporting out of monitoring data that is quality specific within the compliance committee meeting environment as well. But I think to answer the question, typically it depends on the subject matter being monitored. It could be either quality or it could be compliance.
All right, I think that's it. Michelle?
Yes, sir. There are no further questions in the queue. If you have any questions about today's topic, please feel free to email the folks here at their emails listed on this last screen or with me, and I'll share it forward. We hope to see you all at the summit. I know Jerry's got a great presentation planned. Thanks, everyone.
Are we off? Hello?
Yeah, I'm here.
Okay. Hey,
Oh
Maya.
Oh my gosh, I am beyond frustrated, just beyond myself. I don't know what
Maya,
happened.
there's still folks on the phone call. So it's okay. Don't worry about it. It happens. It happens to the best of us. It's all good. And we will talk soon. Take
Yes, sir.
care.
All right,
Bye-bye.
thank you. Bye.